Today's case has to do with a 55-year-old lady that presented to us for corneal opacity secondary to herpetic disease. Unfortunately, she had no prior documentation or recollection of how many times she'd had herpes, how many bouts, how deep, of whether it was herpes zoster or herpes simplex, or whether she had trabeculitis. So we had nothing to go by. We decided to do a DALK after our assessment, which I'll present to you shortly. So whenever you want to do a DALK, you have to make sure that the endothelium is viable or at least good enough. In cases of herpes, which are considered to be high-risk transplants, DALK is much more advantageous, has a great safety profile, and you will always want to get away with doing a DALK if possible rather than doing a PK, especially if the patient is phakic, because the risk of the incidence of cataract formation after DALK is less and it occurs more slowly than after PK. And PK also has greater complications associated with IOP rise and a greater need for steroids, especially in high-risk cases and especially in herpetic disease. So all of these things combined would encourage you to assess the patient and be sure if DALK is possible, and if not, then do a PK. But if a DALK is feasible, then do your best to do a DALK. So looking at the pachymetry map, we can see that the central 5 millimeters are not that thick, so you would see thicknesses that you would normally encounter, but what is particular is that the thinnest point is decentered inferiorly, so that means that the center is thicker and the inferior part is thinner, probably because of the ulceration. And then looking at the ASO-CT, we see that there are some changes on the endothelium, like scar tissue formation or posterior collagenous layer deposition in between duos and decimates, and that is an indication that the endothelium has been affected by the herpetic disease, but not all of it, and indeed it was centrally affected, but maybe if during surgery we could find something, some telltale sign that maybe the endothelium is fine, then we could decide intraoperatively on whether to preserve it or continue to do a PK. And if you want to have both options available to you, you have to do the surgery as if you're going to do a DALK, dissect as deep as possible, and then decide if you're going to conserve the endothelium or take it out. So with this in mind, we've headed off to surgery under general anesthesia. We do our usual DALK technique, which involves partial trephination, probably to 450 or 500 microns, and then deepening the trephination groove with a 15-degree blade, and then bluntly, forcefully dissecting with the Sinskey hook. And then in that plane that we created, we will use the Van Ness scissors to bluntly separate the corneal lamellae, trying not to perforate. Microperforations are sometimes inevitable in scarred corneas, but that's just part of life when doing DALK. So we're taking off the bulk of the cornea, and we're using the Van Ness scissor at this point simply to forcefully, bluntly dissect the scar tissue. And of course, in these cases where there is dense opacity, a scar is always encountered, and that needs to be dissected if possible to separate decimates from the scar. If there was no prior perforation, then decimates is not involved in the scar, and probably you can get away with finding the proper plane. So now we're trying to deepen our plane because, as you can appreciate, there is haze formation and scarring in the central visual axis, and there's no point in leaving the cornea like this. So we're lucky in finding the decimetic plane. Decimetic plane means that we're dissecting what is basically a type 2 bubble if we were to have injected air. But we did not inject air, we just manually bearing Decimase. And the way to know that it's Decimase indeed and not just another layer of stroma is by its texture. If it's rough, it's probably stroma, and if it's very smooth, it's probably Decimase. And the way that it peels off also is a convincing argument that it is indeed Decimase. So Decimase is very easy to break, and this is what we've done here. We created this microperforation, which will prove significant in the post-op period because this patient in particular will have a double AC for about 3 weeks until it attaches. We've done about 3 rebubblings for her, but now she's completely attached. And also you can appreciate that in the center there is some pigment deposition, there's also some scarring, rather haze formation than scarring, because Decimase cannot scar because there's no fibroblasts in it. Some proof of prior endothelial dysfunction and probably present endothelial dysfunction in the central 3 millimeters. But we appreciate that we've gotten this far, we've managed to bear Decimase and take out all the scar. It would be a pity to sacrifice Decimase here, so it's our intra-op decision to keep the patient's endothelium and try to do phacosurgery with or without DMEC later on in this patient's course, because anyway she's going to be better off like that rather than doing a PK right now. Thank you for your attention.